Dear Professor Batrinos, ladies and gentlemen, good morning. First, let me cordially thank Professor Evanthea Kandarakis for this kind invitation, and also congratulate her for organizing such a high-quality educational meeting. In our days, any educational activity in this country should be encouraged because there is a big need. So, now we start this lecture with a case. A female, advised by the primary clinician, because in a checkup was found a high TSH of 6.8. The lady was slightly overweight, FT4 was normal, no thyroid antibodies, they were negative, total cholesterol 182, LDL 92 milligrams per DL, no diabetes mellitus, no hypertension, light fatigability, no more complaints, no cardiac manifestations, medication only, simvastatin 10 to 20 milligrams daily alternatively. Who would start treatment of this patient? Just raise your hand. So, nobody will start treatment? Okay. The outline of this presentation would talk about the aging population, aging and thyroid disease, and treatment of thyroid diseases in the elderly, focusing on levothyroxine. The world population is getting older. Between 2010 and 2015, more than the world population of those over 60 years will be doubled by 4 times, for a ratio 4 times in 40 years. And those who are above 60 will outnumber the number of children below 5 years old in 2020. In Americans, in 2050, 90 million will be over 85 years old. And Greece is a country with high ratio of people aged 60 years and more. We are, with Italy, the second country in Europe. And look at also the Scandinavian countries present a high percentage of people over 60 years old. Now let us see what happens in thyroid with age. First of all, we have a decrease of TSH. Then FT4 and T3 remain stable in serum. Why? Because the deiodinase 1 activity is decreased in the periphery, but adaptively is increasing in the pituitary, so to keep the balance of thyroid hormone conversion, T4 to T3. Then we have in organ-specific manner an increased activity of D2 deiodinase, which converts T3 to RT3, and also T3 to T2. T2, the monoiodinase, T2, which was supposed to be an inert compound, now it's coming up that it has variable activities in the periphery. In the same time, although the mitochondrial activities decrease, the inner membrane complex here is reorganized in a supercomplex, so to keep the mitochondrial, the respiration process active, and leading to higher fatty acid oxidation, acts as a positive, has a positive impact on health aging. And T2 and T3, we know they may have a positive effect on insulin resistance. or to also opposite effect, in other terms, decrease insulin resistance, depending on the degree of conversion, on the amount of T4 and T3. The fall of T3 might be deleterious because T3 is involved in several processes. So it is involved in the structural metabolic shift in total tissue, has an impact on protein post-translational modifications, and also in mitochondrial specific features. For the economy of this talk, I go further. So, in aging people, we may observe an increased serum TSH concentrations with no change in free T4 concentrations. The largest TSH increase in those people with lowest TSH at baseline suggests that the TSH increase arises from age-related alterations in the TSH set point or reduced TSH bioactivity rather than occult thyroid disease. In other words, we have an adaptation process and no an increased incidence of thyroid disease in aging. These statements are corroborated first by this classical study, the ENHANCE study. It's a study to look at the nutrition and health level of the US population. It will be repeated every 5 years. So they found that those people who are between 70 and 89 years old have also the highest TSH level, the red curve, as compared to the other age groups. And also this very interesting study, the Ashkenazi study. Ashkenazi, it's Jewish population living mainly in Chicago and New York. And so they studied these people within the frame of the ENHANCE study. And indeed, it is a population with very high incidence of centenarians and non-Algerians. It means people age 90 to 100 years. So these people had also higher TSH, up to 8 or 10, as compared to the other population of the enhanced study, and also as compared to the younger Ashkenazi people. So the older Ashkenazi had higher TSH as compared to other groups. We know that it has now 10 or 11 years that the Leiden study, they have in Leiden, in the Netherlands, they have looked at the TSH levels of all the patients of all the private clinics in the city. And they have found that those people with a high TSH, age people, above 80 and above 85 years, lived longer, significantly, statistically longer, if they have a high TSH, as compared to the same age population with lower TSH. And then they went back and they take the samples from all the siblings, the parents and the siblings of those people, and they calculated the family mortality history score. What is this? It is a score which defines if there is excess of survival or excess of mortality. The 0 represents the family mortality history score in Dutch, in the whole Dutch population. And so they found that these people who lived longer and had a higher TSH, indeed had a negative family mortality score. It means that they had an excess of survival, as you can see here. And then they looked analytically in the TSH and FT4 and FT3 levels. And look at this very interesting data that the lowest TSH here on the red column, the highest survival rate. And on the other hand, the highest, the FT4, the lowest survival rate. And the same, although a little bit moderately, is for FT3. In other terms, higher FT4 levels means higher mortality rate, always in old and very old people. And TSH, high TSH means live longer. And here from the well-known Baltimore study from Simonsik, which is associated with the previous results, people, older people, they have looked at 600 patients. They have analyzed the thyroid hormones with their walking ability, rapid gait speed, fatigability, energy level. And they saw that those who had a better gait and they had a better walking ability had a lower FT4 than those who had a higher FT4. So again, the FT4 is associated with a better quality of life and lower mortality. So, summarize from what we have said, we can say that at old age, decreased serum TSH and raised serum FT4 levels are related to an increased risk of mortality. Low thyroid activity in humans constitutes a heritable phenotype that contributes to familial longevity. This is the Rosing study, analyzing the centenarians and the nonagerians in Leiden. So now we come to the pure clinic. We know that the rate of the incidence of hypothyroidism and also of subclinical hypothyroidism is rising with age. Here, the classical study by Canaris, the Colorado study, including more than 25,000 people, clearly showed that patients above 74 years may have up to 21% incidence of subclinical thyroid dysfunction, subclinical hypothyroidism. The subclinical hypothyroidism is much lower, no more than 1.4, 1.8%. And also, these people may also have an increased prevalence of metabolic syndrome and of obesity. Look here, the study by Heimat, very recent study published in the European Journal of Endocrinology, that those people with age above 75 years old with TSH, it is according to the TSH, at TSH 2.2 to 10 had a higher prevalence of metabolic syndrome and obesity. So, having said that, who should be treated? In other terms, we have patients with high TSH, old patients. So, should we treat them all? Who should be treated? Of course, taking into account Hippocrates of Elaine Mivlaptin, first do not harm. We know that the thyroid hormone affects many organs and general health. Actually, health is not according to, it's not possible if thyroid does not function properly, because it affects all the system, all the tissues. The causes of increased serum TSH concentration that are not subclinical: hypothyroidism, laboratory analytical problem, it means assay variability, abnormal TSH isoforms, heterophilic antibodies, elderly patients with small increases in serum TSH concentrations, obesity, impaired renal function, TSH with reduced biological activity, also TSH adenoma, a rare disease, also the resistance to thyroid hormones, serum TSH concentration outside of the reference range, which might be normal for a specific individual, because the reference range only encompasses 95 to 95.5% of normal individuals. Hypothyroidism may have severe consequences, reducing the stroke volume, the heart rate, increase arterial stiffness, endothelial dysfunction, and coagulation parameters. According to the recently issued guidelines for hypothyroidism in adults of the American Thyroid Association, a serum TSH is the single best screening test for primary thyroid dysfunction for the vast majority of outpatient clinical situation, and the standard treatment is replacement with L-thyroxine. This is well known and accepted in Europe, but in the United States there are over and over discussion regarding other compounds from desiccated thyroid hormones. So the first option is standard treatment with L-thyroxine. Levothyroxine treatment may decrease the arterial stiffness, restores endothelial dysfunction, decreases diastolic blood pressure, decreases total and LDL cholesterol, restores coagulation parameters, and decreases atherosclerosis risk. However, in the elderly, the need for thyroxine is decreased because of a declining of metabolic clearance rate, declining body mass, and slow progression of disease. And we should also take into account the interaction with other medications. When we have to treat an old patient, we must start with 25 micrograms of thyroxine, and under strict control, we can go every 2 or 3 weeks to 25, depending also of the situation, for cardiac situation, 25 micrograms ahead. Now, I would like to show you some studies showing that if we treat patients with subclinical hypothyroidism, because hypothyroidism is clear. If we have a patient with overt hypothyroidism, we should treat him. The question arises, when should we treat a subclinical hypothyroid patients? And what is the evidence, to treat or not to treat? Here, there's a study, actually in the August issue of Journal of Clinical Endocrinology and Metabolism, including 61,600 patients over the age of 18 years, treated and untreated with subclinical hypothyroidism and heart disease. And the question was, does thyroxine treatment increases mortality in these patients? So here the flow chart, and it was shown that treating these patients with thyroxine, we did not have an increased mortality rate as compared to those who were not treated. In other terms, in patients with thyroid dysfunction, with heart dysfunction, treated with thyroxine does not increase the mortality rate. And a randomized controlled trial of the effects of thyroxine on cognitive function in the elderly. We know that this is also a problem in the elderly. We have a decline in cognition. So the question was, if we treat them with thyroxine, do we improve the cognition function? And there was a randomized control study which provided no evidence for treating elderly subjects with subclinical hypothyroidism with thyroxine replacement. We had no effect on cognitive function. And here, status, it's a big study, in order to determine the baseline thyroid status and incidental atrial fibrillation, and also incident cardiovascular disease and mortality in older men and women not taking thyroid medication. Well, here it was a prospective study looking at the rate of fibrillation and also mortality in those patients with subclinical hyperthyroidism and hypothyroidism. And conclusively, the authors stated that an association between subclinical hyperthyroidism and the development of atrial fibrillation exist in those with subclinical hyperthyroidism, but they did not find any evidence that unrecognized subclinical hyperthyroidism or subclinical hypothyroidism is associated with other cardiovascular disorders or mortality. As you see, there are some controversies in the literature. I present you just a few studies, but big studies with thousands of patients underlying this controversy. And here the cumulative incidence of this study by a couple in JAMA 10 years ago. And you see the incidence of atrial fibrillation in subclinical hyperthyroid is much higher than in the other groups. And also the incidence of heart disease in all the groups, there was no statistical significant change. And this, with a high incidence of atrial fibrillation in subclinical hyperthyroidism, corroborated with the data, the classical study of Sewin, New England Journal of Medicine, in the beginning of the 2000s, clearly showing that subclinical hyperthyroidism and, of course, overt hyperthyroidism are associated with atrial fibrillation and increased mortality. And here, according to my opinion, the most important study on subclinical hypothyroidism and the risk of coronary heart disease and mortality. There was a multicentric, multinational study including more than 55,000 people. And in the context of the study was the association between subclinical hypothyroidism and cardiovascular disease outcomes in the large cohort, in order to assess the risk of coronary heart disease and total mortality. And here, again, there was not found any evidence that subclinical hypothyroidism increases mortality or events from coronary heart disease in those patients in older patients, but with those with the TSH below 10. And because look here, in those with a TSH above 10 to 20, the mortality was clearly increased. So there is a cutoff depending on age and on the level of TSH. This is, I think, very interesting study. And again, here another point from the Baltimore longitudinal study, just to show you that they have found that the half of the patients with subclinical hypothyroidism was due to iatrogenic effect. In other terms, people who were treated with thyroxine had an increased ratio, increased incidence of subclinical hypothyroidism due to treatment. So older people. And so this is also very important. When we treat patients, we must be very careful. Do not induce subclinical hyperthyroidism, because this condition may be maybe dangerous to the older people. Here we have designed with Luca Chiovato from Pisa an hypothetical dynamic of TSH and also according to the studies, to the literature, and so a mortality curve in relation to age. And according to what we know, there is a peak of mortality around 60, just a little bit below 60, 57, 58. And then the curve decreases. So this also might be a point of discussion, who should be treated. And of course, we're living in an age of individualized medicine, and we must take into account the individual, not the levels of TSH and thyroid hormones only, but to look at the patient before start the treatment. Because of all these questions and controversies, the European Thyroid Association wanted to address this issue and has organized a couple of years ago a task force to address management of subclinical hypothyroidism. I had the honor to be part of this committee, and after 6 months of infinitive discussions, teleconference, and emails, we could propose an algorithm that the age below 70, having a TSH below 10, and in accordance to hypothyroid symptoms, yes or no, could observe and repeat thyroid function test in 6 months. If the TSH was above 10, the patient should be treated. In those patients above 70, here again serum TSH below 10, observe, wait and see, and with TSH above 10, consider LT4 treatment if clear symptoms of hypothyroidism or high vascular risk is evident and present. Of course, there are some point of discussions and permanent discussion all over these years, but it was a statement just to start focusing and discussing this issue. We come back to our case. After I have reviewed the literature and discussed with you what is the evidence, how is the field of treatment or no treatment, is someone who would like to start treatment to this patient? Evident no. Consider that this patient had TPO antibodies positive. Will that change your mind? Someone said no. Okay, thank you very much. But look at this. This is a study by Sombaru, Journal of Clinical Endocrinology and Metabolism, 2012. Those with subclinical hypothyroidism, more than 50% remain euthyroidism over 4 years. There was a study looking at the thyroid status in patients with various thyroid diseases, euthyroid, subclinical, subclinical, hyper. Those who were treated with thyroxine, and you see the subclinical, more than 50% remain stable. And only a small proportion of these patients advance to ovarian disease. So this is taking into account that this patient had not thyroid antibodies, we can wait and see. But if the patient had thyroid antibodies, the advance is much more rapid, and we must consider treatment if there are also other confounders, cholesterol, blood pressure, obesity. Exactly what we have said here from the same study, those with anti-TPO positive, we had a higher incidence of advancement to overt thyroid disease. And we come to the conclusions. Several placebo-controlled randomized trials failed to find any benefit of treating subclinical hypothyroidism in the old and in the very old always. The picture is completely different in those below 65 years old. Subclinical hypothyroidism might be associated with greater cardiovascular risk in young and middle-aged people than in people older than 65 years, and therefore treatment is probably most justifiable in this age group. Furthermore, patients aged 60 to 80 years might not benefit because small increases in serum TSH are not indicative of true thyroid hormone deficiency in many cases, according also to Cooper and Biondi. Last, raised serum TSH concentration might be associated with decreased mortality in people older than 85 years old. Before say thank you for your attention, and as this meeting is also addressed to aging and anti-aging, I would like to show you that we know that resveratrol, a phenolic compound, may activate sirtuins, which then by deadecylates the phosphoinositol 5K gamma and activate phosphoinositol P4 and P2, may be involved in the regulation of TSH. We know that RODs may activate the sirtuin family. Sirtuin family, they are the acetylases, very important for longevity. And SIRT may activate also the FOX. FOX family are transcription factors, which have a fork head in DNA binding domain. And so that SIRT, by activating, by redistributing the FOX3 from mitochondria to the nucleus, may have a strong anti-oxidative action and increase longevity. And here the same, the FOX family with a ROS distribution and activating also the cytosol, because mainly they are in the nucleus. Just very rapidly, just to show you that thyroid and TSH might also be involved in the longevity process. And now we are really at the end, and I would like to thank you very much for your attention.